Yeah, live.
A very good evening, everyone. Welcome to iFocus Online, lecture 251, number 38 from our series on squint and pediatric ophthalmology. Today is a special day and a special masterclass from Padma Shri Professor Jagat Ram sir from Chandigarh. It is our honor and privilege to have sir on our platform today evening, talking to us on pediatric cataracts and overview. Sir needs no introduction, but as tradition's sake, I invite Pradeep Sharma sir to welcome him and introduce him to our audience. I've tried to summarize sir's life's exemplary work in the next two slides. So over to you, sir.
Thank you, Shefali. It's really a grand privilege to welcome Professor Jagat Ram, Padma Shri awardee, and really a grand master, I would say, in ophthalmology. For him, we are always privileged to listen to him in any forum, and he's superb whenever he presents on pediatric cataracts. Professor Jagat Ram has been the former director and former head of ophthalmology of Postgraduate Institute of Medical Education and Research, Chandigarh. He was awarded Padma Shri in 2018-19 by the President of India. He's a member of the Board of Governors Medical Council of India and member of National Medical Commission since 2018-21. He has been the director of AIIMS Rai Bareilly till March 2020, AIIMS Bathinda till June 2020, and AIIMS Bilaspur till May 2021. He has received global recognition for innovative cataract surgical procedures. He has been a part of 150 mega eye relief camps in rural areas. Significant contribution in the field of cataract surgical procedures, phacoemulsification, femtolaser procedures, and refractive procedures. He is an excellent surgeon par excellence. And he has been a recipient of more than 32 international and national awards, Best of the Best Award for Innovation in New Surgical Techniques by the American Society of Cataract and Refractive Society Conference at San Francisco 2013. He has won the Oscar of Pediatric Ophthalmology at the World Congress of Pediatric Ophthalmology, Barcelona 2015, Best of the Best Awards at New Orleans, USA 2016. He has delivered over 480 lectures on pediatric and adult cataracts in the national and international conferences. He has contributed over 450 publications in the national and international journals, including a special issue on elimination of cataract blindness in Survey of Ophthalmology. He has been on the editorial board of Indian Journal of Ophthalmology and as a reviewer for several major international scientific journals. I mean, these words are too incomplete to define his personality and his global reaction that he has. He's really superb in the field of pediatric cataract. He's going to deliver a grand master class on pediatric cataract and overview. So over to Sir, Dr. Jagat Ram. Sir, you're muted. Sir.
Yeah, thank you very much, Professor Pradeep Sharma, chairman of the session and one of the best teacher I have met in my 43 year of teaching experience, and one of the greatest human being. Dr. Santosh Hanover, Director, Center for Sight Education and convener of the iFocus. And I consider that iFocus is one of the best education program in the country, and as already said, 251 lecture already delivered, and at present this is the best what we can or the resident or the even the ophthalmologist can have in the country. And I also welcome all the viewers or those who joined, colleagues and dear students who are connected online. I am thankful to Dr. Santosh Hanover for giving me this opportunity to speak on pediatric cataract and overview. First of all, I owe my greatest, sincerest gratitude to all the founding father of our institute at PGIMER Chandigarh. If at any point of time, if there is any problem in the audio or video, you can remind me or you can tell me. These are the director of PGI Chandigarh before me. I was the 12th director of PGI. I also owe my gratitude to my mentors and teachers. My teacher initially were Professor I.S. Jain and then Professor Amod Gupta. I also owe my gratitude to my mentor in pediatric cataract. I got opportunity to work with Professor David Apple in 1993, 94, and then 1998. I also got opportunity that time to work with Professor Emmy Wilson, who initiated my major interest in pediatric cataract surgery. I admire and the pioneer of modern pediatric cataract surgery, Dr. Abhay Vasabada, who inspired me initially, particularly for pediatric cataract surgery. My family has been my greatest pillar of strength and have constantly provided me positive support and affection every day. This photograph on the left side is 1990 and this photograph on the right side is 2022. We have an excellent team at PGI, particularly our long association, Professor Amod Gupta and with Professor Dogra. It was an honor to write the complete issue of Survey Ophthalmology, including the childhood blindness in that, and analyzing the largest database of the world in pseudophakic human eye obtained post-mortem. And it was also honored to publish some of the these images and publication in the New England Journal of Medicine. And this is our patent. This is publications in the Indian Journal of Ophthalmology. From the small beginning, year after year, I have diligently worked to serve thousands of the children who were brought with millions of hope at our doorstep, and to educate hundreds of young minds who want to become leader in ophthalmology. Why pediatric cataract? Pediatric cataract is a avoidable cause of visual disability worldwide. 10 to almost 40% of the childhood blindness is due to cataract. Pediatric cataract surgery is neglected surgical procedure in ophthalmology. There is a high rate of complication in pediatric cataract surgery, such as PCO, glaucoma, amblyopia, and even blindness. Restoring the sight of one child blind from cataract may be equivalent to restoring the sight of 10 elderly adult. Most powerful draw was preventing childhood blindness due to pediatric cataract. This became my biggest passion, mission, and obsession. I developed completely focused motivation and strong will to turn that into reality. These were some of the publications which had made global impact in pediatric cataract surgery. And over the past almost 43 years, my career in ophthalmology, particularly in PGI, I have documented a lot of these pediatric cataract. So I will be speaking on pediatric cataract and overview. Almost 1.5 million children blind worldwide. Pediatric cataract account, according to another one of the estimate, almost 7 to 15.3% of the pediatric blindness. The prevalence of childhood cataract is almost 1.03 per 10,000 children. That varies from 0.3 to 22 in 10,000. It is much higher in the low socioeconomic group. Congenital cataract is associated with ocular abnormalities in 27% of the cases, with systemic abnormalities in 22%. most of the unilateral and significant number of bilateral cataract are idiopathic in nature. Crystalline and connexin gene mutation are the most commonly described non-systemic, non-syndromic inherited cataract. As already said that most of the cases, it may be idiopathic etiology, but genetic contribute very significantly from 8 to 25% of the cases. Intrauterine infection account for 10 to 15% of the cases, and rubella is one of them, and which is occur much more commonly. Metabolic causes contribute 8 to 10%. Galactosemia, hypocalcemia, hypoglycemia, and dehydration contribute significantly. Trauma also contribute to 20 to 30% of the children having cataract. Then other are prematurity and syndromic cases. These were the children, all of them visually significant. Majority of these children have bilateral cataract, almost 80 to 85%. 10 to 15% of these cases have unilateral significant cataract while they present to us. It is important to see each of the child after pupillary dilatation and document the morphology, such as you can see in the upper left and middle, these are the zonular cataract, while in the lower part, it is first slide is the lamellar cataract, and the last slide is the posterior lenticonus. Here you can see again different varieties of cataract, varying from the tripod cataract to just rosette shaped cataract. Rosette shaped cataract most commonly is found in trauma. Why we have to dilate the pupil? Because you may detect that many of these children, they may have coloboma or they may have subluxation. These were the children with the rubella cataracts. These children, particularly rubella cataract, they have small cornea, they have microphthalmos, strabismus, and these are the patient where you should not implant intraocular lens. Even simple cataract surgery is difficult in these children. Although this is extremely rare, bilateral anterior subluxation, dislocation of the lens into anterior chamber. This is of course rarest, where there is a double crystalline lens, as you can see in the right eye. Here, this is the magnified image of the same. What are the various issues? What we have to do before taking decision? One is IOL power calculation is extremely important. Intraocular lens power calculation in those children where we are implanting IOL, where axial length of the globe is 17 millimeter or more, where corneal diameter is 10 millimeter or more, we go for IOL power calculation, and IOL power calculation should be aimed for moderately hyperopic postoperative refractive outcome to compensate for the myopic shift which is expected in children due to axial length elongation of the globe. IOL can be implanted, as I already said, in those children having axial length 17 millimeter or more and corneal diameter 9.5 to 10 millimeter or more. SRK-T and Holiday 2 formula considered best and having excellent post-operative outcome in majority of the cases where axial length of the globe is 20 millimeter or less. Even in certain cases, it may be difficult to get this IOL power calculation using these formula, then initially while I started that point of time, I used even Dahan's estimate. This is not a formula, this is estimate where we do 20% under correction for children less than 2 years and 10% in children from 2 to 8 years. In fact, later on I realized that it leaves behind much more hypermetropia. So we have to reduce this further from 20% to almost 12 to 15% in the first 2 years of life. So these are some of the how much is the axial length of the globe in at birth, almost 16.6 to 17 millimeter. Keratometry is more from 48 to 51 diopter, and which decreases over a period of time, over a period of 12 months to 43 to 44. Most of the cases where any of the case where we cannot measure the keratometry, and there we do this A scan and IOL master in those who are cooperative, but in the theater also we do axial length measurement and then K reading by the handheld keratometer. These are the Dahan's guidelines, where according to axial length we choose the IOL power. This was done initially while I started. Even certain time while we fail the other measures, then we may adopt this. Pediatric cataract management is a teamwork. But any of the child which we see, particularly bilateral cataract and those having systemic issues or problems, we show to pediatrician. Then anesthetist is important part of the team. Of course, genetic consultation is sought in particularly bilateral cataract and where there is a familial involvement. I think counseling has to be done very, very meticulously. What are the various important consideration for cataract surgery? One is dilated slit lamp examination, IOL power calculation. We have to keep in mind the increase in the axial length in these growing eyes. We have to take decision whether to implant IOL or not. Then many of the children, they may have marked postoperative inflammation. Extremely important is following these patients, children in the postoperative period and managing amblyopia. Timing of the cataract surgery is extremely important. If child is having bilateral cataract, to prevent stimulus deprivation, amblyopia, dense visually significant cataract, bilateral cataract need surgery. Most of the time we do 6 to 8 weeks. This is as per books, but we may do it 4 to 6 weeks most of the time. We do not wait for long time. If child is fine, there is no problem with the anesthesia, we go ahead with the cataract surgery. But in unilateral cataract, visually significant cataract, definitely we go for surgery earlier than bilateral cataract. Counseling is very important. We have to counsel parents and guardian regarding the type of surgical procedure which will be performed on child's eye. We have to explain the difference of the growing eye of the child compared to the adult, and the issue of changing refractive error. And also we have to emphasize the need of long-term follow-up after cataract surgery for so many issues, even to detect complication and manage them. A need for compliance of the follow-up, use of spectacle and occlusion therapy. All this must be explained to parents. goal of the pediatric cataract surgery is to have clear visual axis and complete long-term visual axis, which should be clear for a longer time. And so visual rehabilitation, whatever some residual refractive error will be there, that has to be compensated by spectacles. I will be showing some of the videos. Here is a child having zonular cataract. This is to show to the beginners that how we stain the anterior capsule and do continuous coronary capsular axis. Size of the capsular axis is kept around 5 mm. This is followed by cortical cleavage hydrodissection and removal of the cortex from the capsular bag. So here it is after evacuation of the cortex from the capsular bag. Then we do primary posterior capsulotomy, and the size of primary posterior capsulotomy is kept around 3.5 mm or so. If you fail to complete it, then you can also complete it with the retractor. In the central area, particularly in the zone of posterior capsular axis, we do limited primary anterior vitrectomy. In all cases, we implant hydrophobic acrylic IOL, mostly in the capsular bag. So here this, now we go to the next video. How we do optic capture. This is a diffuse white cataract. Staining of the anterior capsule is done, and flattening of the anterior capsule with viscoelastic, and then initiating the rhexis and completion of the rhexis using Utrata forceps. And then removal of the cortex from the capsular bag. Even any of the cortical fiber which is there in the capsular bag is removed. And then initiating the posterior continuous curvilinear capsular axis. Because here I am demonstrating the optic capture. That is the posterior capture, where optic of the IOL is placed into the vitreous cavity and haptic in the capsular bag. Do not hesitate to place suture in the main section. And here is this post-operatively how it looked like. Even we have done study on the femtosecond assisted pediatric cataract surgery. There may not be very significant advantage, but this is just to demonstrate that what advantages it offers. So this study was done in 12 cases. Actually, problem is that we have to do the we have to anesthetize the child, and perform the docking, and then we have to position the incision. Placement of the side port incision, and then placement of the main incision. These are the various adjustment, and then various parameter must be adjusted perfectly. Here, this is the main incision, then side port incision, and this is the completion of the procedure. Then while doing this shifting the same child to the main operation theater, adjacent one, and then we have to separate the incision. This is just to demonstrate that although rhexis is already done, removal of the anterior capsule, removal of the cortex and nucleus from the capsular bag. Then here we are ready to do primary posterior capsulotomy. And here is the implantation of the hydrophobic acrylic IOL into capsular bag. Removal of any vitreous strand, or performing the limited primary posterior capsulotomy in the zone of posterior axis. All the incisions were closed. This is post-operatively, and then we go to the other different situation, that is PHPV. Here, this is a vascularized posterior capsule. Sometimes it may be very, very thin capsule in such children, as you can see, but I could complete the rhexis, anterior rhexis, and then posterior vascularized membrane, that is cauterized. It is very difficult after making a nick in the posterior vascularized membrane, which is cauterized. You have to cut it with the scissor, because even cutter will fail to cut it or do precise posterior capsulotomy. So here we are cauterizing the stalk of PHPV, and then vitrectomy has to be done in the zone of visual axis, and implantation of IOL and whatever vitreous tag, it is removed. And so these are some of the animation which shows, and these are the other cases, some classical cases of PHPV. Even some such dense cases we have operated. Anyway, we have to follow these patients up for a longer time, and in majority of the cases we achieve quite favorable outcome. And these are some of the other challenging cases which we have encountered. Such as double crystalline lens, posterior lenticonus, microphthalmos. Here is a first case, which is a classical case of posterior lenticonus. The same case rhexis is done, and removal of the cortex from the capsular bag. And we have to do vitrectomy, whatever. Now we have to stain it with triamcinolone. Vitreous, each tag of the vitreous need to be removed. Now, this is a child with the double crystalline lens, which has close to 9-year follow-up. This is both of the lobe of crystalline lens. Continuous curvilinear capsulorhexis has been done, and we customized the IOL for this child, where this customized IOL is implanted into each of the capsular bag, and you can see the optic, and this child could see, and we did amblyopia therapy, and we demonstrated that child could see from this eye. I have done a follow-up of more than 9 years for this child. This is another situation where there is a 8-year-old child and having astigmatism. We have used Callisto in this case. A removal of the cortex from the capsular bag. And here we are using toric IOL, and it has to be placed very, very accurately into capsular bag. Because child is 8 years, we have not done primary posterior capsulotomy, but alignment has to be perfect. This is another child with juvenile idiopathic arthritis. You can see 360-degree posterior synecdoche. A Malaysian ring is placed. Completion of the rhexis, and then removal of the cortex from the capsular bag, and then implantation of IOL into capsular bag. In this child also did the peripheral iodectomy. This is one child with the lenticular coloboma. Here issue is not only placement of IOL, but issue is removal of the posterior synecdoche, and then stabilization of the capsular bag, which is not so easy, it takes time. Capsular hooks were placed to the capsulorhexis margin. Removal of the cortex from the bag, and then this is just for fixation of the capsular bag. This is a Sioni ring, which is placed in the capsular bag, and here we have placed a toric IOL. And you can see that so nicely. I think you can see before and after surgery. It is perfect centration of IOL. This is one rare case where there is a hemorrhagic type of PHPV. These are very common. This is not rare. These are not rare cases. Out of the 10 or 12 children which we used to do every day, or sometime even more than that, there may be 1 or 2 child with PHPV. So it is not uncommon. So this is a very thick stalk, vascularized stalk, which need to be cauterized. Otherwise there will be bleed into vitreous cavity. how we implant the IOL and do the optic capture. This is a simple optic capture. These are the cases of toric IOL, which we have documented before and after. Toric IOL implantation is possible in selective cooperative children undergoing cataract surgery with pre-existing corneal astigmatism, because you have to mark child has to be cooperative. And up to 6 years, study shows that you may not do toric IOL implantation because there may be change in the astigmatism. We have also done study on multifocal IOL. These are the study from Jacobi, whereas we have done in children 5 years or more. We kept the scope for further growth of the globe. This study concluded that multifocal IOL are viable options for children above 5 years of age, provided decision to implant IOL is backed by thorough pre-operative counseling, appropriate case selection, and post-operative amblyopia therapy. And almost 2/3, that is 66% of the cases, they achieved good near and distant vision. And these both the study, that is toric IOL and multifocal IOL, these are published. These are some of the studies on persistent fetal vasculature. Then it is extremely important to have follow-up of these cases for prescription of glasses, amblyopia therapy, before this suture removal is done. Then very important to remove suture. Parent must ensure that child wear prescribed glasses, and these children are followed up 4 to 6 weeks initially, then every 3 months for EUA, retinal examination, IOP, and refractive correction, and then visual axis obscuration if there is any. Initially, we have to use more topical steroid and has to be tapered over a period of 4 to 6, or sometime in children, particularly 6 to 8 weeks. This is one of such picture in the post-operative period, and these are the outcome, and shows excellent visual, clear visual axis. These were initially about 25-30 years back when we used to get pharmacia IOL, and inflammation or fibrinous uveitis is common, which need more frequent topical steroid. So sometime you may get this type of PCO, which need surgical capsulotomy or YAG capsulotomy. You may see over a period of time such lens epithelial cell accumulation. If it is not, if it is very peripheral, you may not do anything. If it is encroaching the visual axis, you have to aspirate it. These are some of the others, and PCO is quite common. Pupillary capture is also common if it is IOL is not in the bag particularly. These are the sometime IOL pigment on the IOL surface which you see. And if parents are not compliant for putting a homide or dilator, then iridocapsular adhesion is quite common. Occlusion therapy is the mainstay to achieve optimal visual outcome, especially in unilateral cataract. And sometime we don't, where we do not implant IOL, we have to, we use phakic spectacles. These are the various children where different type of spectacles, you know, so heavy are used, and it is particularly designed to hold the spectacle in position by the parents, particularly JIA and uveitis cases where we do not implant IOL many of the time. we may leave them aphakic. Contact lenses are viable options, but has disadvantages at our setup. These are some of the publications. Outcome of unilateral cataract in infant and toddler. Incidence of the complication, reoperation and glaucoma was low when the surgery was performed between 7 to 24 months, as compare if it is done 7 months or less. This TAFS study showed that IOL implantation is relatively safe in children older than 6 months and younger than 2 years. This is the another part. 5-year follow-up showed in bilateral cataract particularly revealed low rate of visual axis opacification and rare glaucoma, but it is much more, glaucoma incidence is much more in younger age group, those having surgery less than 6 months. These are the other outcome of these in children followed up over a period of 10 years, shows that 1/3 of the patients in aphakic group were still wearing contact lens to correct aphakia, but there was no difference in the outcome. This is regarding the axial length elongation, which was similar in both the groups. I have followed up the children for even more than 30 years. This is one example. This child was operated in the first year of life in 1997, and another photograph on the right side. That point of time also primary posterior capsulotomy, anterior vitrectomy, and IOL implantation was done. This is 25 years later, same child with bilateral pseudophakia, having 20/20 added visual acuity, and this boy has done MBBS. Most importantly, the words of Ellis are worth remembering. Young children with an IOL in place are unique clinical responsibility of an ophthalmologist. Long-term follow-up is essentially important. I think there is no way out. We have to see these children over a long period of time. There will be, I think in the ending, there will be some few other slides. But in conclusion, I can say pediatric cataract surgery should be carefully and meticulously planned and performed with or without IOL implantation. Primary posterior capsulorhexis and anterior vitrectomy in younger children reduces the rate of PCO. Younger children means that those children 6 years or less, particularly we do primary posterior capsulotomy. And if we feel that even older children, even up to 8 year, 9 year, we feel that the compliance will be poor, there also we do primary posterior capsulotomy because otherwise there will be 100% PCO in these children. Long-term follow-up is mandatory as the rate of complication is high in such cases. Now I am going to show some of the slide. Ophthalmology in general and pediatric cataract in particular has been my life, and it has given me many moments to be proud of. Coming out of this presentation, this is
Dr. Jagat Ram, Chikitsa Netra Vigyan.
And other proudest moment of my life was Best of the Best award at the American Society of Cataract and Refractive Surgery in 2013, 2016, and winner award in 2018. And this is a few seconds.
Now the winner in this category reminds me, I watched this video over and over and over. As some of you know, I have loved magic from the time I was a child. As I watched this video, I realized that the producer had to love magic too. In producing this video, you can see the level of skill, compassion, and technology that went into showing what we as ophthalmologists can ideally do. This is magic. The winner is management of double crystalline lens. Jagat Ram from Chandigarh, India.
I am thankful to ACRS. I am thankful to judges of this film show and audience also. And as well as I am thankful to patient. Patient came to me and I planned it that what to do. So I am really thankful. It is a great honor for me. Thank you very much.
You've heard your patients say over and over, "Doctor, you performed a miracle on me." This, to my mind, is a miracle and magic. You do it every day.
And we received all these award at ACRS and elsewhere also, even in Milan. And another proudest moment for me was when I became director PGI. I joined this institute PGI in 1979, and I was, I may not tell the story, I was sitting below the Safeda tree and somebody came that you are selected. So I was not knowing anything. And however, when I joined as a director, I assumed charge in 2017, 17th March. I felt humbled by the enormity of the task that lays ahead. Over a period of 5 years, PGI became the second best institute in the country after AIMS New Delhi in the NIRF ranking, and became one of the best institute over a period of all the 4 years, best institute for organ donation. Other proudest moment was a member of Supreme Court mandated MCI oversight panel and NMC, that is the National Medical Commission. In the end, Swami Vivekananda once said, take up one idea, make that one idea your life, think of it, dream on it, and live on that idea. Let the brain, muscle, nerve, every part of your body be full of that idea, and just leave every other idea alone. This is the way to excellence. Once again, I am thankful to Dr. Santosh Hanover, who is the role model for Indian ophthalmology, who has brought ophthalmology to the top. Particularly, you can see the Indian Journal of Ophthalmology, where it was nobody used to read about 30-40 years back. But now everybody is reading, and it is as good as Journal of Cataract and Refractive Surgery. It has gone up from 0.8 to almost 2.96, or it will be much better, much higher. So he is the person who has done so hard work. I'm also thankful to Professor Pradeep Sharma, who is a role model, one of the most humblest person I have seen in my life, and a great teacher. Once again, thank you very much. And I think I completed my presentation. That is 50 minutes dot. I will be happy to have any of the question from you, whatever I can answer. I'm sure I may do more, but sometime if I cannot answer any question, I'm sure I can answer, but then Professor Pradeep and Dr. Santosh Hanover are there.
Thank you so much, sir. Thank you so much for gracing our platform with your presence today. And not just a proud moment for you, but as ophthalmologists, as Indians, proud moment for us also with all your work and accolades. Pradeep sir, Santosh sir, any words from you before we go on to the questions?
I think it's been a kaleidoscopic journey for us. Like a child, we can say, like seeing in the kaleidoscope, his fascinating videos and photographs, and the way he has presented all these magical moments, rightly worded by Spencer Thornton as a magic that he was displaying. So, and it was really proud for all of us Indians to have the national anthem being played.
Yeah.
So it's really a great journey, sir. Your obsession, passion, and mission has really brought us such a splendid nectar that we are all enjoying now. So thank you for that splendid lecture, sir. It's no words can be expressed fully.
Santosh sir, before you go on to the questions.
It's really wonderful talks, a wonderful and magical journey, and it shows that focus can achieve magic. You're focused on one particular entity, that is congenital cataract, apart from doing everything else in cataract and cornea, and that has actually paid a lot of dividends. Congratulations.
Thank you so much. If there will be any question, I will be happy to answer.
Yes.
Because I was told that at least keep 10 minutes. So I rightly kept 10 minutes.
Yes, sir. We have a few questions. The first one is, what is the ideal size of posterior capsulotomy?
Yeah, posterior capsulotomy, size of the posterior capsulotomy is almost 3.5 to 4 millimeter. If we do bigger capsulotomy than 4 millimeter, you may not be able to place the IOL in the capsular bag. So it is better to keep the size 3.5 to 4 millimeter. If we do very small capsulotomy, it may be, contracted, and it may produce visual opacification. So ideal size is 3.5 to 4 millimeter.
So the next one is, what is the earliest age to operate unilateral congenital cataract and bilateral congenital cataract?
Unilateral congenital cataract, they are operated early because it is a unilateral cataract. There are chances that there will be much more amblyopia, development of amblyopia in unilateral cataract. So these children are operated from 4 to 6 weeks. I have operated, this is in general, I follow the principle 4 to 6 weeks. And child should be able to tolerate the anesthesia. So if there is no risk, surely I think 4 weeks is the earliest time. I have one child which was operated at 21 days, and that was followed up for a long time. Now, after about 30 years, child is having almost 2.5 diopter of myopia. But that is not much because that time, 30 years back, we were not 100% sure that how much refractive error a child will get.
So what about insertion of IOL, like in unilateral, bilateral? Does the age vary? Or we do it?
No, my decision for placing the IOL, if the child has axial length of 17 millimeter or more, and corneal diameter is 9.5 millimeter or more, there we place IOL. And if it is microcornea, microphthalmos, or any other abnormality, then we may not. Particularly microcornea and microphthalmos, it should not be implanted because these children will get glaucoma, or there are very, very high risk of complication.
Okay, sir. And sir, what about the treatment of amblyopia post like the cataract surgery? How exactly should we treat it?
This is, I think, a very important question. And while one thing is that we do not, in particularly amblyopia, particularly unilateral cataract, we do not try to keep very high hypermetropia in these cases. Otherwise, we try to keep these children hypermetropic to compensate the myopia. So we keep less hypermetropia. That is one. Second thing is that while we say that we do patching of the better eye, that is the normal eye, where in case of unilateral cataract, so we tell the parents that use correction, and they use correction in the operated eye, and opposite eye occlusion therapy. Occlusion therapy is extremely important. If suppose there are several children, even unilateral cataract, they come very late, say 5-6 years. Even there we implant IOL, and we do not keep much of the hypermetropia in the post-operative period, and we give extensive amblyopia therapy. That is, I think, 6 to 8 or minimum, because if we give less, then it may not be effective. But younger children, definitely, I think you cannot give 6 to 8 hours. You have to give less according to the age.
Okay. Pradeep sir, your experience with treatment of amblyopia post cataract surgery?
I think what he said is right. Basically, that's what we would be following. Correct. Just a question I have, like bilateral cataracts, sir, when would you like to put an IOL? When you are operating on bilateral cataracts, would you be like more likely to be leaving them aphakic? And what will be your indication for putting intraocular lens implants?
Bilateral cataract, surely, and almost 100% of these bilateral cataract, if they are not microphthalmic, or if there is not having microcornea, it is better to place IOL in the capsular bag, and depending upon the age, do primary posterior capsulotomy and anterior vitrectomy. But if there is a contraindication, many of them, microphthalmos and microcornea, and how much is the axial length. So in these children, I will like to surely put IOL.
Okay. So it's same as the unilateral cataracts, you would be now more likely to be putting an intraocular lens rather than leaving them aphakic, which was probably the earlier practice. That bilateral cataracts, we were more often leaving them aphakic and then treating them with secondary intraocular lens implants.
Yeah.
So the next one is, can you throw some light on the IOL power calculation in various ages, sir?
Yeah, definitely. If child is younger than 2 years, particularly in the first year of life, then using any of the formula, if we can do the axial length and we can do the keratometry, which we more often do for small children, particularly in the operation theater. We do axial length in the operation theater and do their keratometry with the handheld keratometer in the operation theater. We try whether we use SRK-T formula or Holiday or any of the formula, we keep these children almost 12 to 15% under correction. But usually, according to Dahan and many of the other people, they suggest 20% under correction. But if child is 2 years or more, we try to do less than 10%, 5 to 10% under correction. And in unilateral cataract, particularly, correction is much less. Under correction is much less. So we don't try to keep them much more hypermetropic in the post-operative period.
Okay, sir. And so best contact lenses for aphakic infants?
In particularly in unilateral cataract, although I personally, we have a separate, this soft contact lenses they are used, but older children, even hard contact lens is used. But most of the time, meticulously they are followed up, and we tell parents to remove during the night time.
Pradeep, sir, your experience with contact lenses in aphakic infants?
So I think that has been a challenge mostly. Yeah. Yes, sir. Carry on, sir.
I do not practice this contact lens, but we make sure that these children get visual rehabilitation by contact lens.
I think it's been a challenge putting contact lenses in India with the type of patients that we have. That is the reason that we have more and more gone for intraocular lens implantations whenever there is a possibility. As Dr. Jagat Ram has mentioned, that we are veering more towards intraocular lens implants, knowing very well that otherwise they have little more risk when we are putting in IOLs compared to leaving them aphakic. But since the other advantages are outweighing those risks, we are preferring to put an IOL in whenever possible. Contact lenses in our country is a problem because of getting the again and again in the children. So in bilateral, of course, we don't use contact lenses at all. We are, if not IOLs possible, then aphakic glasses are the ones which we are using. And in unilateral, yes, when IOLs cannot be put, then contact lenses have to be used with all the problems explained.
I think that is very right. Particularly, majority of the children, they come from the poor socio-economic status. And using contact lens and even teaching parents that how to place the contact lens, how to remove, that become a big problem. Maybe I think selectively, definitely it can be used.
The next question is actually about the aphakic glasses. Like, what are the disadvantages of aphakic glasses in bilateral cataract, if not contact lenses?
Definitely, there are certain situations, particularly those initially operated JIA cases, juvenile idiopathic arthritis cases, where if there is a posterior segment inflammation, these children, we keep them aphakic. So there are several disadvantages because, as I show in one of the slide, these glasses are very heavy. If child is microphthalmic, it may be 15 to 20 diopter, or it may be more than 20 diopter. It is difficult to get even more than 20 diopter glasses made, aphakic glasses made. They are very heavy. They may slip down. Even parents try to keep the some cord or some thread, tie the spectacles and haptic so that to keep them in position. There are much more scratches, and I think there are several of the magnification and other, I think every one of us knows, but there is a tremendous problem even in the school, that how they use bifocal and other besides scratches and keeping them in position, and several of the lot of disadvantages.
So, and sir, like in cases like we also send our retinoblastoma kids for cataract surgery where we don't do a posterior capsulotomy. What care should be taken to avoid PCO formation in like such pediatric cataract surgery, sir?
Where if there is no indication of doing primary posterior capsulotomy, although we do in 6 years or less, younger children, If it is not done, I think that is not right. But older children, say 8 year or more, one is placement of IOL. One, we use always hydrophobic acrylic square edge IOL. All these IOL, modern IOL are square edge IOL. Even we never use silicone IOL in these children or hydrophilic IOL in these children. I prefer only hydrophobic acrylic. These are square edge IOL. And particularly younger children, definitely we have to go for primary posterior capsulotomy.
But sir, in cases like retinoblastoma, when we send our patients for pediatric cataract surgery, we don't do a PCC. So in such cases, are any extra step that we should take for avoiding development of PCO other than the IOL type fusion?
Yeah, definitely. I think that is one of the issue. But we had several cases of retinoblastoma, and I have documentation of them also, because reflex is not a red reflex; it is a yellowish reflex. And another is that these are the retinoblastoma which is treated by the our oncology team, and after they do, initially they used to do even cryo and even laser. After they are treated, in those cases, once I think they say that now it is quiet, we place IOL, and definitely in majority of the cases try to avoid primary posterior capsulotomy, because spread will be much faster through the that will communicate. You are right, absolutely right.
And so can multifocal IOLs be placed in pediatric cataract, like when we are operating them? Multifocal IOLs?
I think it is not always indicated, and it is selectively it can be done. Whatever we do very selectively. One is the best multifocal IOL, such as VBT or any of the best IOL. Those initially there were other Alcon IOL available, but now there are much superior IOL available. But we have to have, one is the cost effectiveness. Another is that we in younger children particularly, where we know that there will be still we have to do under correction. So that has to be kept in mind. Particularly very young children, I think we should not do. 8 year or more. Definitely we can do, and they do very well. Even with multifocal IOL, definitely they will do very well.
And so the last question for the day is how to manage refractive changes following IOL in children as they grow up. Like you showed also some cases of children who are now adults. How to manage the refractive changes when you place an IOL?
Capsular changes.
So refractive changes.
Power changes, refractive power
changes.
Refractive power changes. I think definitely, as I told, I think this is one of the most important question. What happens in a growing eye? I think initially we keep them hypermetropic. They will be such as plus lens. Then it goes toward we have followed them up over a period of 30 year. Initially it may be plus 5 diopter hypermetropia. Say after 4 year or 5 year, it may be plus 1 diopter hypermetropia. Then after 10 year, it may be just minus 1 diopter, and 20 year, it may be minus 2 or like that. So we have to have their follow-up, compliance to follow-up, and change in the whatever glasses comes or whatever their number comes. That is extremely important. This is one of the biggest problem, particularly compliance. But majority of the children, we tell them, we do the counseling of the parents before that you have to show your child till late. Because this is very important, change of a number, they will not have good vision otherwise. So it is almost, as Illy said, it is a lifelong follow-up for the children, or it is a long-term follow-up for the children.
I think with that, we conclude our questions. Again, thank you so much, sir, we were like really lucky to listen to you. I think 1 hour was too less for your talk. And thank you for gracing our platform. Pradeep, sir, concluding remarks.
No, I am thankful to all of you. I am thankful to Professor Pradeep Sharma. I am thankful to Dr. Santosh Hanover and you, Dr. Shefali. And I think it is an honor for me to speak here. And Dr. Rolika is also there. She initiated about 7:30. We were doing trial. So I am thankful to each one of you. It is a great opportunity for me. And it is a vast topic, and it needs many hours. If we have to definitely get feel of it. But anyway, whatever we do in day-to-day practice, that is what I said. Thank you so much. It is a great honor for me.
Thank you, sir. Thank you. Thanks, Shefali. Thanks, Rolika. Thanks, Dr. Santosh, for organizing this event.
Thank you, sir.
It's really great.
Yeah.
Santosh, any words?
So next will be November 4th. It is again an exam special, long cases by Dr. Siddharth Agrawal. So see you all on November 4th. I hope all the hot seaters join us and we'll have a good discussion.
Good night.
And let me remind you all that iFocus online is going to continue, but iFocus offline is also going to happen. So all the postgraduates, please register yourself very soon. We have limited slots. So the sooner you register, we will be able to arrange things for you better. Thank you.
Thank you. Good night, everyone.